There we go. Hit the go live. I'm like, which button am I hitting? Good morning, everybody. It is a very interesting day in my life because it is the 17th of May, which, if you are Norwegian, you know is Norwegian Independence Day. So happy 17. Mai to all of my Norse friends out there. And I see Ross Hadley grinning off screen, like, yep, it's our day. So it is Norwegian Independence Day. And it is also time for Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And I am your host, Lisa Salberg. And I am joined today by a dear friend who, my goodness, I don't know, I got to go back to think about the year that we met, which I'll get to in a moment, Dr. Marcos Hazday. And he's down in Orlando, Florida. I remember the first time we met was, well, we met by phone, and then we met at the summit, the second or third summit in Minneapolis. So it's been many years because we're on summit number 8 this year, this October. Get your tickets now. So, Dr. Hazday, welcome to Tales from the Heart.
Thank you. Good morning. Yes, we met in the fall of 2009.
2009. Wow. It's been a long time. And the world has changed a lot in HCM since 2009. And I was hoping that we could talk a little bit about it and see what it is that we might be able to teach and educate and inspire folks to want to learn about regarding HCM management, medical management May. That's the topic of the month. So I am going to just ask Dr. Hasday, where do you think we are in 2024 when it comes to medically managing these patients?
Well, Lisa, I remember in that particular summit and many others that I have attended, the disclosures that were given by the speakers. And one of the particular ones I remember is all the medications that we use for ACM are off label, including all the medications that we use to do MRI with enhancement. So a lot of things have changed. Things have been approved, which are based for the first time on randomized trials. For the first time, we actually had data on metoprolol and exercise, which we never had before. But we also have very exciting data uh, on the long-term benefits of the myosin inhibitors, and I see it in my practice. People that normally would have gone to septal reduction therapy, I don't see it happening. I still refer one or two here and then that have severe mitral valve, but my patients really, really, both objectively on the numbers that I get on the follow up, which means nothing if the patient still feels terrible, but also how the patients feel on the new class of drugs, which is tailored based on the molecular basis of this disorder. So, very exciting to have that.
I agree completely. I'm just going to give a backstage shout out to Ross. If you could go into the Facebook page and share to the group, StreamYard no longer allows us to share to the group. So if you can go onto the Facebook side and share it over to the group, that'll let people know that we're over here today. I don't know why, but Meta has changed their algorithm and their ability for us to share in within a private group through through our streaming. So if you could go find those people and let them know where we are. So anyway, um, so we now have tailored medications for those with hypertrophic cardiomyopathy for the first time pretty much ever. And I am just a few hours back from the ESC Heart Failure Conference in Lisbon, Portugal. So if I look a little tired, I spent pretty much all day yesterday on planes, a little tired. But the great news out of Portugal and the ESC conference was the data released by Cytokinetics on the Sequoia trial. Not to take anything away from how much mavacamten has done for patients and continues to do and will continue to do for patients. But there are going to be options in myosin inhibitors, which we never really had any options before. It was here's some beta blockers, here's some calcium channel blockers, and that was it. Maybe some diuretics, some antiarrhythmics, but here we are with not only one, but the second coming down the road myosin inhibitor. How is this changing your management of patients with HCM, Dr. Hazday?
Significantly, Lisa. So we used to discuss the clinical profiles according to many papers that Dr. Maroon has written and who is at risk for heart failure or no. And we will identify that in a subgroup of the patient, which is actually two-thirds of all the patients with HCM, uh, have the obstructive type. If they had a resting gradient greater than 50 or provoke greater than 100, we will look at those patients early on for septal reduction therapies with surgery. If the patient had many comorbidities and was not an ideal candidate for thoracic surgery, then we will explore alcohol septal ablation, of which I had a very small percentage of patients uh, completed that procedure. With the result of the work that was done in a Cleveland Clinic, the Valor trial, we see, and for the first time, we have objective data on a peer-reviewed journal that mavacamten may obviate the need for septal reduction therapy, which is what I see in the I have a cohort of patients now between 34 36 patients receiving mavacamten. I have found that it's well tolerated. We haven't had a drop in the left ventricular ejection fraction, and the gradient has significantly dropped in all of them but two. And in those two, I'm in the process of getting from 5 to 10, 10 to 15, whatever it takes to, and then at that point, we will make a reassessment. But the great majority of patients have had a very favorable response.
So there's also something we don't see very often in HCM, and it was published 3 days ago in the New England Journal of Medicine. But the results from the Sequoia trial actually made it to the New England Journal. So aficamten for symptomatic obstructive HCM was published a few days ago, and it's just exciting to see so much energy and so much positive outcomes in these patients. And I think it's really going to change the face of the future, as is something we really haven't talked about much on the podcast, and that's the sesame procedure, which is not done by many centers, but I know Atlanta has been perfecting it. And they finally published, well, not finally, but they've published some data where it's quite impressive the remodeling that happens in the heart with the sesame procedure versus a traditional myectomy. So, less invasive, less recovery time, really good long term data is coming from that study as well. So, there's just so much to do for patients today that I sit in awe of where we are. We've come a long, long way since 2009, don't you think?
We have, and there's actually a new trial in design. There's a class of medications we are using now for patients with congestive heart failure with preserved ejection fraction. That is a significant number of our patients that come to the emergency room with congestive heart failure have normal systolic function. And in that large group, that some of them may have hypertensive heart disease and a small group may have cardiac amyloidosis, but a significant number of our patients that are non-obstructive uh, with hypertrophic cardiomyopathy, um, well, some of the serum glucose co-transporter inhibitors have been approved for diastolic dysfunction, but they have not been studied in this particular group. And I am excited to see that that may occur, and then we will have data on that too. That class of medication, even though may have some nuisances of adverse effects, such as frequent urinary tract infections and just it is a game changer for other people in reducing hospital admissions and improving quality of life. So it's something to be looking forward to as well.
So we're dealing with myosin inhibitors SGLT1, SGLT2 combination. We're dealing with the new Embrya phase 3 trial, which is more about cardioenergetics and the way the heart's using ATP. And what else do we have? So we have the new AFI, we have all these other things coming down the pike. What about um, what about the weight loss category of drugs, the GLP-1s? What do you see their role in HCM becoming, or do you use today? So the Wegovy's and the Ozempics, do you see they have a role here?
Well, I am optimistic they will. I do not have data on that, Lisa, but obviously we do know that patients with HCM we have encouraged to obtain ideal body weight and also level of fitness rather than so many patients came to our clinic with the idea that they couldn't do a thing, and we have changed that. Something popped on my computer. I want to take it off here. So, Lisa, yes, I think that there may be an important. Can you see me well now?
Yep, you're fine.
Some echo reminders came over here because you need to read echoes. I'm sorry. I will read them by the end of the day.
Busy doctor.
But
Time
not
never stops.
okay. So yes, I do think that we are beginning to see, as you know, a lot of these medications at the beginning were prohibitively expensive, and the third-party payers did not wanted to pay for weight loss reduction. But if they had a cardiac indication, I think that would change.
I would hope so. We've seen a lot of success, but we don't have a lot of data. So we need more safety data to make sure that we are perfectly safe to use these drugs. It does appear that way, but I would like to see a larger trial. But we'll see how that works out over time. So if you had a patient today with non-obstructive HCM who was mildly symptomatic, is there particular drugs you would try, things you would not try? Are there any trials that you would be hopefully looking to this patient to learn about, not necessarily participate in? We just want them to learn about it. It's up to them whether they want to or not. What would you do with a non-obstructed patient today?
Well, I with time and with much better echoes, the quality of our echoes with better equipment, global longitudinal strain, and I have become really uh, fascinated by how well we can diagnose diastolic dysfunction. And if
Mhm.
my patient has diastolic dysfunction, I do put them on empagliflozin at this time, and I have a conversation with the patient because obviously, if the patient has congestive heart failure and the end terminal, I practice a lot with markers. So if my patient has an elevated end terminal pro-BNP, I may use some preload reducing agent such as a diuretic. But most of our patients that have symptoms of congestive heart failure, they are not wet in the lungs. So I may avoid the loop diuretics altogether and perhaps treat the patient with spironolactone or empagliflozin and see if I can get away. Traditionally, we have been told to slow the heart rate down a little bit. Obviously, uh, yes, every reduced heart rate will allow more filling time, and those things are in theory great. But like to see the data, like you just mentioned a few minutes ago.
Yeah, we definitely need more data, and hopefully we'll see that the myosin inhibitors have a role in the non-obstructed population. But
Indeed, I'm excited about that, and it always makes sense when I makes made sense when I first read the Explorer, in which they did not use for that particular first report non-obstructive patients, or they did not. How about the patients that have mid-cavity obstruction, which I have now, that they don't have the typical LVOT obstruction with systolic anterior motion, all the requirements for mavacamten. Well, I think that newer trials are including those patients. I'm excited to be participating in, hopefully being site activated for one, in which we are going to study patients that are non-obstructive with New York Heart Association Class 2. I always struggle because most people feel great, but then you ask, can you take a flight over stairs, or you have difficulty taking the garbage out, which is one of my duties at home. And they say, yeah, when I overexert, I do have shortness of breath. Well, guess what? That is class 2. That's not class 1, New York Heart Association. So, with a proper history and conversation with the patient, I may elicit that they have symptoms.
So you bring up a really good point about recognition of symptoms, and I kind of chuckled that at ACC in Atlanta, um, I'd been using a line with some of my friends over at BMS, and I didn't realize that it caught the ear of, I guess, their marketing people. But the slogan was "Fine isn't always fine," or "Fine isn't fine," and that's what we tend to tell our physicians as patients. How you doing? I'm fine. Well, are you short of breath? Well, yeah, but I always am, so I'm fine. Well, do you get short of breath walking upstairs? Well, yeah, but I've been doing that for 20 years, so I'm fine. We think that our disabilities and our limitations are normal because we've learned to live with them. So we don't tend to report the specifics in the way that we should to our physician. So we just come in and say, I'm fine. But you're completely correct that they're telling you that they're a New York Heart Association class 1, but they're probably a 2 because they've just acclimated to the heart that they have. So we're underway to hopefully give better tools to clinicians and researchers to identify, like, what is fine and what are the limitations here. So we're in a project right now with the creator of KCCQ to evaluate whether or not we could create an HCM specific KCCQ so that patients could communicate in a language that the physician's going to understand, and we'd understand what is the mechanism of why they're not feeling well. If it's obstructive, we expect to see one set of answers. If it's non obstructed, we expect to see a different set of answers. But in the end, if we treat them well, we should see these numbers improve and show a lower burden of disease. We don't have great measurement tools in HCM. Do you feel that having a more specific tool would help you make sure that you're not just hearing "I'm fine" and you're actually getting how they're feeling? Would that be helpful to you?
It will be helpful. Actually, well, and this is uh, something that is not commonly done unless you're in a lab, like we have here in the hospital, but most offices, outpatient, don't have a way to, for example, do cardiopulmonary stress testing. I mean, those are very more sophisticated trials. If we had something, I mean, test. If we had something simpler than that, that we could put a level, like, in research, we do the living with heart failure questionnaire, Kansas
Yeah.
City, right? And there's 30 questions here. If we could have something more simple that we could identify, yes, I think it would be very helpful.
We agree, and we're trying to help develop that right now. So stay tuned, and hopefully we'll have something to share with the world in the next couple of months. We're excited about that. So to help manage your patients medically, other than the the compounds, the drugs that you can offer, is there any other advice you give to patients about their lifestyle, their weight, their mental health? What do you think is important for patients to do to manage their HCM outside of taking drugs?
Okay, without being hypocritical about it, I do advise my patients with AFib to reduce alcohol consumption significantly. And I actually mentioned to them that the success for radiofrequency ablation goes hand in hand with abstinence from alcohol. I have seen it with my own eyes. I see who is compliant, who is not. But on that line, what has changed in my practice with the management of our patients that often develop uh, atrial fibrillation, as many as 20% of our patients may develop atrial fibrillation at some point. It's the nature of the beast, elevated left ventricular diastolic pressure, left atrial enlargement, blah, MR, whatever, all the factors that make atrial fibrillation possible. I'm moving to radiofrequency ablation. I, it's possible. I don't know. I don't know who's watching this, but it's possible that people that I have now, like 3 or 4, in the waiting for RF ablation, Um, we have moved towards going more early into that before there is more a worse substrate to work on, more fibrosis, etc. We are preferring for radiofrequency ablation early, and that has changed in my practice over the last 6 months. And I think that the new guidelines encourage to consider.
I
Uh,
was just going to bring those up, and I'm going to lean off screen for a second because they're sitting over here, and I have to lean a little further to grab them hot off the presses last week. It's been a big couple of weeks, lots of big data dropping. So let's talk about the new guidelines for a bit. There's not a lot of changes here, but there's some refinement. And let's stick with topic for a minute. So you were talking about atrial fibrillation, which is actually the top of table one of the guidelines, mentioning that there's a revision in section 6.5 for heart rhythm assessment, and that extended monitoring is recommended annually now for patients at risk for AFib. And so as soon as that left atria becomes more dilated, we want to be very vigilant of whether or not AFib is popping up before there's clinical understanding of it. So we're doing more to address AFib in terms of finding it, but there's really no change in the guidance about how to manage it. But there's really good data in there on the role of radiofrequency ablation. So, do you want to talk a little bit about that revision? It's a 2A indication now with level of evidence. I'm sorry, not level of evidence, but a guideline listing of a one. So it's a should do. You want to talk a little bit about that?
well, what I can add about it, Lisa, is that many patients that have atrial fibrillations are asymptomatic or may occur during the sleep hours. And sometimes also a relation, you mentioned weight, ACM, and we should throw that sleep apnea, which is something that could improve with less alcohol and a few less pounds. But they all correlate with atrial fibrillation. I do think I have been monitoring my patients um, younger than 60, yearly, periodically, but with regards to the risk of stratification for sudden cardiac arrest. And of course, you will catch people like that with atrial fibrillation, but having that guideline, because there are people that already they are low risk for sudden cardiac arrest, they don't need a defibrillator. So I think it's important to do that monitoring. And, to back that up, how many times all of us that have patients with ICD, when they come to the clinic, I say, you had 2 hours of ICD, of atrial fibrillation. You didn't, oh, yes, you have 5% AFib burden. They may tell you, doctor, I didn't even know that I was in atrial fibrillation. It's not the first time that I have to convince a patient that they should be on anticoagulation, even they didn't feel a thing. It was difficult for me to make the case, but data is data. I have objective evidence of AFib. Untreated AFib can have devastating effects when it comes to embolic events and causing several vascular accidents. So I think it's an important recommendation.
I think it is too, and I like that it went from a 2A to a 1. I think that's very, very important. So another topic that is near and dear to your heart is the use of implantable defibrillators. So there's been a couple of, I would say, modifications related to ICD selection, and it comes in section 7.2, patient selection for ICDs. We've taken the age off of it. So in the second guidelines in 2020, for patients greater than 16 years of age with one major risk factor, the 5-year risk of sudden death should be assessed before putting an ICD in and shared decision making. Changed to also a 2A for patients with HCM with one major risk factor, ... So they cut off the ages. Now, you primarily see adults, but what do you think about this change on age?
Well, uh, how does it differentiate, Lisa, with what we have heard in many meetings that sudden cardiac arrest is rare after age 60, provided that the patient doesn't have an apical pouch on the MRI or leg gadolinium enhancement or somebody, we are not even using gadolinium anymore. They don't have replacement fibrosis more than 15%.
Mhm.
Uh, those patients that only have one risk factor and they are 62, and let's say that they have non-sustained VTAC, well, that is a lower risk patient.
Yeah, they're not really addressing the upper age limit. They're just removing the lower age limit at this point in the guidelines. While the data is there, and I believe it's in the preamble or in the not preamble, but within the document itself, I do believe that they reference the 60 and older should be looked at slightly differently. I think that's really important. Lately, I've seen a lot of people with new diagnosed HCM, 59, 60, 61, 62, and not being seen by high volume experts and getting devices put in really quickly for symptoms that could most likely be related to obstruction. So they're missing the obstruction still and they're seeing the disease and they're jumping in with the device and they're over 60. I think we need to slow the roll a little bit and make sure that we're doing proper patient selection. Devices are not without risk and complication, physical, financial, and emotional. So we need to make sure that it's a balanced discussion. Would you agree?
Absolutely. I have been referred a patient. I have not seen the person yet, but I have seen the echo, and I discussed with the electrophysiologist. This particular patient has had three syncopal episodes, and I know the age. It's not 60, but less than it's less than 60, but in the 50s. And the electrophysiologist was very prudent. He was not convinced that this was an arrhythmic syncope, and he wants me to see the patient and help him determine whether the patient really should have an ICD, which was is great of him to have done that. It could have been neurocardiac syncope. I asked if they were on exertion, which if the syncope happened on exertion, could have been done to obstruction. But most important, I told him that I wasn't going to say a word about the ICD until I see the MRI
Smart
and see,
idea.
and see what the substrate is. So I'm glad that he didn't rush. Syncope, recurrent syncope, ACM, she needs a defibrillator. Well, no, no, let's just take a deep breath because although ICDs, and as you know, I have been involved with ICDs since my training, right? I believe since 1988. I at that time I had to do it with a surgeon, and we used to do the ICDs by placing epicardial fascia. We have gone a long way with the ICDs, including doing them subcutaneously now. So yes, they are good, but they are recalls and they are malfunctions and they are inappropriate shocks, and all these things need to be taken into consideration in the decision making.
I'm a huge supporter of ICD therapy in the right space, but if you don't need one, they also have their downstream consequences. Although I don't even know if you know this or yet, know this yet or not. But I now have a pacemaker in my transplanted heart. So I went with the leadless technology, which if you told me 15 years ago I would do something like that, I would say, "Oh no, that technology is not for me." Well, it was for me. So we keep an open mind and we keep evolving and technology stays a step ahead of us, thank God. At least we hope it tries to. So new data on that, just removing the lower age group. And then dealing with the conversation on medical management for May. There's two medical management changes in the guidelines. The one is quite obvious. It's section 8.1.1, and this adds myosin inhibitors to the treatment regimen as a class 1 indication for those with obstructive HCM. I think we're all on board with that one right now. And then the second is the use of valsartan in those. This classification is very specific. Younger than 45 with non-obstructive HCM due to a pathogenic or likely pathogenic sarcomeric variant with a mild phenotype, it may be beneficial to add in valsartan. This has got the least amount of data behind it out of anything else on the revisions that I've seen. If I'm incorrect, somebody correct me. but this has got kind of the lightest evidence. It is a to be. It's not a should, it's a could. Can you discuss the use of valsartan in the non-obstructed and how you view that?
Lisa, I will have to review if it is, because of course, a lot of the medications that we use have a pharmacological understanding, and in the case of valsartan, it's an angiotensin receptor B2 blocker. But I know that that will not be the case on how it works. If it does work for ACM, it's a biological effect. So I would like to see how those, what is the molecular mechanism of that before I go further. We always have been interested on this type of drug, for example, in Marfan syndrome, how does it interfere with the um, pathogenic variants? So I like to know a little bit more about it and what is the data. Certainly exciting. If you could use a medication that can modify the genetic expression of the product, is always welcome, but I like to review that.
Yeah, I would like to see a larger study on that as well. That's just one of those ones that's going to take a long time. It's just going to take a lot of years to see what happens to those patients if they progress into something or not. And I don't think our current trial design likes waiting that long. We want our answers in like 3 to 5 years and we want to move on. But this one I think is going to take 10 to 15 to really see what happens. So we're still in that window and hopefully we'll gather more data and learn more about it. And then the other changes were related to recreational activity, basically encouraging people to move more. Obviously, after expert evaluation and their gradients evaluated and their risks of sudden death evaluated. Um, but we want people to move. We've been saying this for years and years and years. Move, walk, keep active. Recreational sports are probably good for some, if not most, and competitive athletics for the right patient after the right evaluation with an expert who understands not only the HCM heart, but the athlete's heart and the combination. So they're adding in a recommendation to be seen by a physician that specializes in HCM and athletes. And there are only about a small handful of those. So hopefully they're not going to get overwhelmed with work. Sorry, guys, if you do. But what do you think about those recommendations? On point, need more data.
No, I agree. We all know what are the psychological effects of telling a young athlete that he cannot participate in competitive sports. We also have an idea who are the highest risk patients. So there is a lot in between. The ones that are super high risk and the ones that are not. And right now, many of them are being excluded. I think that I going to absolutely going to somebody like you know, let me just say the program in Morristown will be a good idea.
So you're referring to Matt
Before he
Martinez.
gets, before he gets 200 phone calls to say, refer from me. Uh,
Yeah, I think he's a little busy already. So we have a few really good sports cardiologists. Dermot Phelan in South Carolina or North Carolina, Michael Emery up at Cleveland Clinic, Matt obviously in Morristown. Um, Obviously Barry Marin has commented on this type of population for many years. So there are still some expert opinions out there that are available. If you need help getting appointments, just give me a call and I will do what I can to assist you in finding a sports cardiologist that might be more local for you. But those are kind of the big guys that are in the game right now. So there's a lot to be said for getting a good assessment. We have NBA players now who have HCM and ICDs, and that's great that they're playing. It's great that they can be protected, but it's not going to be a blanket. Every athlete can play every sport that they wish because their anatomy and physiology may dictate that it's just not the right option for that particular heart. And I feel really bad for the people that are told that it's too dangerous to follow their dream. And we really need to think about the psychological well-being of those individuals. But there are more important things sometimes than your chosen vocation. Sometimes you need to pivot, and that's okay. We spend our lives pivoting into different opportunities based on lots of different things, and sometimes it's our heart. Any other thoughts on recreational or competitive athletes?
No, Lisa, but if clarify me on this if I'm not correct. In previous recommendations, implanting an ICD so somebody can play soccer is not an indication,
It is
correct?
still not an indication.
Correct. That's
In
what I.
fact, it is a um, so let me put my glasses on. Starting to feel a little bit aged here. So there's no indication. There's actual what is it? Is it harm? So recreational physical activity and competitive sports. So the new recommendations stay for patients with HCM. Participation in vigorous recreational activities is reasonable after annual comprehensive and shared decision making visit with an expert professional who balances potential harm and benefit. That's a 2A. A 2B, which is slightly lower evidence as it was in the valsartan data for patients with HCM who are capable of high levels of competitive athletics. It may be considered after an expert provider experienced managing patients with HCM and conducting annual comprehensive evaluations and shared decision making that balance potential benefit and risk. And for most patients, there is no universal restriction from vigorous physical activity or competitive sport is not indicated. There's no benefit there. I did see something about not, I forget where it's written, but you this still the recommendation stands that no, you don't put an ICD in and let somebody play sports and see what happens. That's not a risk factor. Sports is not a risk factor for consideration for an ICD.
The reason I mentioned that is because people have asked me that. I mean, what if I get an ICD? So I have to answer. It's not an indication, and the ICD is not free of its
Risk.
own set of complications.
Yeah. Yeah.
But certainly, we're moving for a much more liberal attitude towards sports and ACM. I think that's welcome to have the ability to discuss this and share decision making.
So I think it's important that we separate two groups here. It's the under 18, the child, and the over 18, which a day doesn't change your ability to understand risk. So at 17 in 11 months, are you going to make a different decision than you did at 18 in 1 month? No. But there is liability and the legal ramifications of a child participating in sports versus an adult participating in sports. So I think we're going to have to take some time to learn a little bit more about how to carve out which activities are safe for which age ranges and provided it a bit more clarity. We're getting better. It's not just a no, but it's not just a yes. If you're gonna play football in the South in the summer with a gradient of 30 or 40, that's very different than playing doubles tennis or playing basketball inside of a more air-conditioned environment. So all of these variables need to be considered, and that's why this is an expert conversation, and maybe not every HCM center is going to be able to address the nuanced issues of the sport chosen and the risk it entails. So I would highly recommend that working in collaboration with your local center, that maybe you reach out to a national expert.
Absolutely. Yeah.
Okay. So we have medical management May, we have new drugs, we have gene therapy around the corner. What are you most excited about in the HCM space in 2024?
Well, obviously, although this is not available at this time, I think that for me that has a background before I became a doctor, heavily on biochemistry and molecular biology, which I keep it to this day. I have a very strong cardiogenetics program here. The ability to understand what was the underlying cause of the disorder and having in the future the possibility of do a gene editing, I think is very exciting. I mean, there are very few cases now. The entry criteria For example, for the patient that has a recognized pathogenic variant in myosin binding BPC3, it's a very small group of patients. They have to be non-obstructive. They have to have a defibrillator, and then those patients will have gene editing with an adeno-associated virus that target, etc. It doesn't cause permanent change on the genome of the patient. I think this understanding is fascinating. Um, so I am so fascinated. I mean, I recommend whoever has a vague interest on this subject to read The Codebreaker. It's a book. It's not for doctors or scientists. It's for everybody. It's kind of the discovery of CRISPR, and I mean that is to me, well, obviously for me because I like that. I found it very interesting the way that it was written and what are all the applications that I see that from that technology are occurring in ACM, in amyloidosis, in muscular dystrophy, in sickle cell anemia. I think that this gene editing to cure a disease or perhaps to give it is not there yet to give it before it becomes a problem. Can you imagine that?
Well, I think we have to look at it from two sides. We look at the family planning side, and that is today we can use IVF with um, genetic selection. So you do the IVF retrieval, you get a handful of embryos in a petri dish. You select a cell, you test the cell. If it does not carry the gene, that is one that can be implanted. If you do carry the gene, that embryo is not implanted. That's the way you can stop disease genetically in a family with HCM and ensure that you stop the disease to about a 90% certainty. You're still dealing with a single cell, and there are still errors that have been made, and babies are born that we thought were gene negative, and that 10% comes in. So we have that as an option. And then if you were to wait, or it's not feasible because your children are already born, um, the concept of gene therapy through AAV9 delivery. So a virus delivers the information of the missing protein and delivers that to the heart. That's the hope, but it doesn't change reproductive health. So if you fix it in that individual, it doesn't mean it's fixed in the next generation because it doesn't impact the eggs or the sperm. So you can still pass on the genetic mutation. So we're in fascinating times. It's not ready for prime time by a long shot, but I believe for a number of reasons that this is eventually going to work out. Um, how expensive is gene therapy? It's unpriced at this point because we've not developed one for a cardiac condition yet. It will be in the millions of dollars if I were to guess, potentially like $2 to $3 million, which makes it unaffordable for like most people if you didn't have insurance. So the insurance providers are now catching up, and I'm answering this question over here. And that's from Kim. Is it expensive? They're trying to figure out having children. So PGD is affordable for most. And depending upon the state, some of the IVF might be covered. And if the insurance company was smart, they would spend the $50,000 on IVF rather than the $2 to $3 million on gene therapy later. So we have a way of stopping disease potentially with PGD. Gene therapy, we have dosed 2 patients so far. The data is not public yet on what's going on. I'm currently operating under the impression that no news is good news, but I don't know. I don't have any other data. Another company may be coming to market for a trial very soon. These are complicated trials. You can't do a healthy volunteer thing. You just have to find somebody with a genetic mutation that's willing to try. So if you have an MYBPC3 and you're interested in trying and being a trial participant, you can learn more about it by contacting us and we'll put you in touch. So, what are your thoughts on IVF, PGD, this whole other space of medicine? Are we going down the right path, the wrong path? Are we going down a rabbit hole? Where are we going?
No, I do offer it to my patients. Um, I do see quite a bit of patients that are younger, and some of them obviously are already pregnant, and I do have a clinic that follows according to the guidelines. And I teach my fellows. We uh, put into play the data for publishing in JACC of CAR, PREG, which is the patient that has cardiac disease and is pregnant, and uh, ACM with obstruction does increase the risk a little bit, but most patients that are pregnant tolerate. So I do offer the advice of the ones that are doing family planning and have a recognized mutation. I do happen to have a great doctor in Orlando. She is in Winter Park, and she's a reproduction endocrinologist, and but she does in vitro fertilization. She's great. She understands this or that. Every patient takes it differently. Lisa. I have had patient. I have one person that since I've been her doctor, since she used to come to my office with her mother, we have had conversation in depth. And one day she went and met this doctor, which is in Orlando. Her name is Dr. Jaffe, and came back to my office and said, Dr. Hazday, I have elected not to do it because had my mother done that, I would not be here. But how can you argue that point, right? I mean, that's what she told me, and we are best friends. But for some people, they do not want to have the anxiety. Well, in that particular family that I'm referring, everybody has an ICD. So it's a little riskier in this particular group because they have been identified. Not every patient that has a positive pathogenic variant, as we all know. I know that you have a well-read group of people following this, but not every family has sudden death in the family, but some of them do, and this particular family does, and this particular patient does have an ICD, and so does her father. So if there is a child with the same gene, well, at one point, probably this conversation will take place about a risk of sudden cardiac death and prevention. So, yeah, there are many benefits not to have to worry about having a child with the condition, but it's a personal decision.
So many, many, many years ago, it may have actually been at the summit I met you, maybe in 2009.
I remember the family that Dr. Maron invited and came
Yeah,
in. I
from the
really,
Philippines.
I remember that couple.
So after that talk, okay, we were in the same place at the same time. So I walked out to the coffee break, and this pediatric cardiologist, whose name I don't remember, came up to me and said, "What are you going to do to stop this?" And I went, "I'm sorry, what just happened here?" And he said, "If they were right, you wouldn't be here, and you wouldn't be alive." And I hadn't given that much thought. And I just turned to him and I said, "I wouldn't know. And somebody else would be here. And they might have a completely different life or a similar life. I don't know. But if I could stop suffering in my family and stop somebody from being disabled in the way that I was from my HCM, I think that is a profound statement of love from parent to child. And I would have done anything in my power to stop my daughter from having HCM. Unfortunately, she was conceived in 1994 and this technology was not available. But I wish that it were, and I wish that I didn't have to give that burden to my child, and it would have been the first gift I could have given was to not pass on the family gene. But we all make our own decisions, and that's the beauty of this all, that it should be between us and our physician as to what is the safest, most efficient, appropriate way to start our families. And there shouldn't be anybody else involved in that conversation. We don't want to go down that rabbit hole now.
But one thing, Lisa, is, and I have to emphasize that, and this is from Dr. Maron's uh, words, okay? So I don't want you to think that they came from me, but with this condition, you can have normal longevity, normal quality of life with contemporary management.
Absolutely correct. Absolutely correct. And for the majority of us, I mean, I am here because of proper management. I am I'm sorry, somebody's knocking at my door. I
They
am here
probably
with
telling Lisa that I have to teach my fellows at noon time.
yeah, I have to go here in a minute too.
We have our journal club at noon, and maybe Julie is telling you.
Actually, it's Elena. I've never had somebody open my door while I'm podcasting. I'm like, what's happening? I didn't know if there was a fire, but there's not. So, anyway, getting back to topic here, Kim asked a question that I do want to answer before we run away, and I pulled out a prop for it. So, Kim is saying that she found out that she has a gradient of 68, but it's, quote, in the middle of her heart. So, I brought up an hourglass to explain what mid cavity HCM can look like. And it looks very much like an hourglass, where in the center of the ventricle, the muscle is bulging and you get this hourglass type shape that can occur when, at rest or, a valsalva or with stress. So that's called a mid cavity obstruction or a mid cavity presentation of HCM. And there are some patients currently being treated with myosin inhibitors for this type of obstruction. It's a little hazy whether it should be or shouldn't be based on the label, because it refers to outflow tract obstruction, and this is mid cavity obstruction. But I know many people who are on a myosin inhibitor with this anatomy, and it does seem to be working quite well. So I hope we get some clarification on how to handle the mid cavity folks in coming data in the next few months or year or so. So we've got that. So we both have things to get off to today. This will not be our last conversation on podcast, but before we end today, and we were just talking about babies and stuff, but this little baby that I'm about to show you was created the old-fashioned way. And I have a new addition to my family as of yesterday. And for those watching, this is the face of a little baby angel who joined us yesterday. Her name is Gloria Louise, and she is my nephew's first daughter, with his wife, Kimberly. So, John and Kimberly, congratulations on adding the third to your family, three under three. It's going to be a bumpy couple years, guys. Have fun with it. Enjoy the moment. So, Gloria, if you spell it out, in the middle is Lori, which is my sister and John's mom. So her name is Gloria, and that's a nod to her grandma, who sadly never had a chance to meet her. So we added to the family. It's always bittersweet. I always think that, boy, I wish my sister was here to see this. So welcome to the family, Gloria Louise. And Dr. Hazday, thanks so much for joining us. As we're both running a little bit late, we don't have time to talk about the Portuguese wine that I just drank, but we'll hold that conversation to next time because you're pretty good with those wine things now, aren't you?
I don't want to give the wrong impression after I took the wine from my radio frequency ablation, but yes, there is a particularly lovely one that I like. It's called Crisea. Just look it up, Lisa. Crisea. Chrysia.
And tell everybody, other than being a cardiologist, electrophysiologist, what's that other little certificate that you earned?
Well, I did wanted to become a sommelier, and I I I earned it. I mean, there was an auction at the church of my wife, uh, which is Greek American, and there was an auction to have a course by one of the members who is a master sommelier, how to become a master sommelier. And I didn't want to do it because of being a wine snob. Those of you that know my personality, I just really like to learn, whether it's tennis or wine. And I really, really, really enjoy learning how to become a master sommelier.
Anytime you need to practice with a glass of wine, I'm available.
Yeah, I always told my wife that when I retire from cardiology, which might never happen, I want to become a sommelier at Walt Disney World in one of those restaurants. All my patients retire in Walt Disney World and they still keep working.
I like that idea. That is a good retirement aspiration. All right. Well,
I got to
I'd like,
run to teach my fellows a journal club now.
I think I have to go do something too because they're looking for me. So I just want to say thank you to all of our sponsors. And thank you to all of our HCMA Recognized Center of Excellence partners. You'll hear a little drop on those in a minute because Joey will add that in post-production. So I thank you all for joining us today. And Dr. Hazday, as always, a pleasure to speak with you.
The pleasure was mine, and congratulations on that baby. Bye bye.
Thanks. Bye-bye.